filled those gaps. So it's a good tool. It's a self-assessment tool. All facilities can use that, fill that themselves, and they can send it through NHSRC to us or to NHSRC, and you can yourself evaluate the score and you can see how temporarily over time you are able to fill those gaps. So we will hold a brief training on that, and then we would request all of you to fill those self-assessment, assess yourself, and fill those Excel sheet and send it to us so that we can keep it as a record. And then at a defined frequency, you can fill that again to understand how you have filled those gaps. So with that brief background, I request Dr. Jain Srivastav sir from NHSRC to give the welcome address and to help understand the participants on what they need to do. Thank you, sir. Over to you.
Thank you, Professor Purva Mathur and the colleagues, and our NHSRC colleagues. And also on behalf of both the partners, All India Institute of Medical Sciences and National Health System Resource Center QPS Division, we extend a very warm welcome to all the participants, which in fact now I can see about 160 odd people have logged in. And I'm sure that in few login, there will be more than one person physically being present over there. At the outset, in fact, we are grateful to you and All India Institute of Medical Sciences and ICMR for supporting this endeavor, which will go a long way in strengthening the quality and the safe health systems in the country. Because the fact remains that if we are talking about the quality, we are talking about the strengthening the health system, that the things cannot be viewed in isolation. I mean, frankly, we don't know that what is the extent of the harm which, because of healthcare associated infection, it happens in the public health system per se, mainly the district hospital and lower down. Because over the period of time during last 16, 17 years, particularly after the National Health Mission has been launched and by the states missions, the states' own efforts, lot of strengthening has taken place, more so during the COVID time. All the states got the further impetus. Besides their own budget, there had been few initiatives by the central government. But unless we know that where do we stand, and then only we can plan that where we want to go ahead. So the basic, in fact, like Professor Purva Mathur just now mentioned, that the first step comes up that kind of willingness, which by your attendance now it has come to 180. I can imagine that we have the willingness. Now the next is that if we want to do certain initiative, those of you who have worked in the quality side, please recall the PDCA approach or the PDSA approach, whatever you may call it. Plan, do, check and act. And in the planning process itself, the next thing comes up that making a baseline assessment. And I have gone through these tools. It is a very basic thing where this is starting from team formation, the local leadership, which in fact the subject matter experts will take you through. They will also orient you. So this data is not going to be going outside where a facility or a state will be put in the back light, in a bad light. The idea is that let's try to know that where do we stand, and then plan certain actions, because we do realize that it will not be possible to close each and every gap in one go. But unless we know that these are my 10, 20, 15 gaps, and then only we can prioritize and plan them, because that resource allocation is not a major problem. All these things, additionalities, which in fact if the state wants, there are n number of the budget head under the NHM are available. Starting from the infrastructure strengthening, there is a separate budget line. For HR trainings, there is a separate budget line. Somebody is complaining about my sound not being there. Deepkar, Arpita, somebody can confirm?
No, sir, you're perfectly audible.
Thank you. Thanks so much. So please look at your end. From our side, our online, in fact, the participants, they are able to hear. So budget line is not a major problem. Budgets are available. Besides this, under the quality budget, there are activities for the kayakalp. You can demand for the money over there. There is a in fact budget line for the quality. You can demand the whatever the budgetary support is required over there. Most difficult challenge is going to be improving upon the process part, which we'll plan later on. So as of now, our request is that please undertake the assessment, form the small teams, and let it be the joint effort by the teams, whether the microbiologist is available over there or not. I know, we are fully aware that at many locations, microbiologists may not be there per se, but whoever is available, whoever is responsible should join this endeavor, and so that we take it forward. And as articulated by Professor Purva Mathur, that these tools will be shared on the email also. And I'm told that the certificate of the participation which you will be getting, there will be a link over there. My colleague Dr. Deepka Sharma will be sharing an email ID. Please share with us these filled in checklist, and let's define on the timeline. Today we are talking that it is the 9th. So expect that it is not a very lengthy one. Should take about 7 to 10 days time to complete this exercise and revert back to us. So can we keep it say around by 20th, 21st, we'll have the first filled in available to us, so that we move ahead and we move ahead fast. The idea is that we don't have indefinite time, and wherever there is a willingness, those facilities can do it immediately. If there are certain facilities, there are challenges which are coming up, they can plan a bit later. But broadly in this month, let's try to complete this exercise, and preferably by 20th, 21st, within 10 days time. That would be great. And before I conclude, we are again grateful to Madam you, Professor Purva Mathur, for having been with us in this journey, hand holding, and you are always there to bank. So once again, thanks very much, and let's move ahead with the technical session.
Thank you so much, sir. That was very encouraging, and I think the timelines are perfect. 10 days are enough for self-assessment and filling and sending. So I think by 20th or 21st, you should be getting that. And any support you want, you can always approach us. Dr. Rasna will put that in the chat box. Our email ID, Rasna, please put that. See, any site which is having any problem with any question, they can always approach us.
Sure.
With that, thank you, sir. And I request Dr. Rasna to start with the technical session. Thank you so much.
Thank you so much, ma'am. I'll start sharing my PPT. Can anyone confirm? Is it visible?
It's visible in the slide mode. You can, yeah, now it's perfect.
Thank you, ma'am. Good morning, everyone. Good morning, my respected professors, my seniors, and my juniors. So, I'm Dr. Rasna Parveen. I'm working as scientist C in the Department of Laboratory Medicine at AIIMS New Delhi under Dr. Professor Purva Mathur in the C2C project. And today I'm here to talk to you about the IPCAF tool. What is exactly the IPCAF tool, how we use it, and more specifically, why we use it. So I thank you all for joining this session with me, and I'll try to make it as much simple as it is for you. I request all of you to please type in the chat box your name, designation, and institute. So I'm starting with my PPT. Just give me a moment. Yeah. So uh, basically, Before going into the IPCAF tool, let us discuss about a bit on IPC, infection prevention and control. So what is infection prevention and control? Infection prevention and control is basically an scientific evidence-based approach which helps to prevent the healthcare workers as well as the patients from having or from causing any harm due to avoidable infections, more specifically due to healthcare associated infections. So IPC is the foundation for reducing healthcare associated infection as well as antimicrobial resistance. It helps to contain the emerging pathogens. It helps us to prepare for an outbreak and also ensures quality care for patients as well as healthcare workers alike. We have a set of evidences for why IPC is so important for patient outcome. So, effective IPC program leads to more than 30% reduction in HAI rates. We have also observed that improving hand hygiene practices may reduce pathogen transmission in healthcare by 50%. And surveillance contributes to 25 to 50% reduction in HAIs. So this has been observed through various studies. But now we all know that in order to see how our child is doing in studies, we need some kind of evaluations, right? So again here, in order to see how our IPC practices are, we know that we all have IPC practices in our healthcare facilities, but we exactly don't know whether we have good IPC practices or not so good IPC practices. So in order to know that, we need to have certain evaluation too. And here comes the IPCAF tool. So IPCAF tool is basically infection prevention and control assessment framework at the facility level, which was designed by WHO. IPCAF tool is a systematic tool that provides a baseline assessment, that is the initial assessment of the IPC program, practices and activities that is there in your healthcare facility. It is generally based on the World Health Organization guidelines on core components of IPC at the acute healthcare facility level. And it helps you to have an ongoing evaluations through repeated administration. By repeated administration, we means you can have a self assessment as well, so that you can document your progress over time and thus facilitate improvement. So why we are using IPCAF tool and what is its purpose exactly? Suppose you have a child and you want to go for his admission in a particular school. So if CAF tool is nothing, it is similar to somewhat like a progress report card of your child. So when you are taking your child to a school for admission, the school authority will assess his initial knowledge in order to see which class is more suited for him. So if now when the school authority assess his initial knowledge and suppose say he scores 300 to 400 marks out of 500 and then he is admitted to a particular class, but at the same time the school authority may notice that the child may need certain improvements in the subject, say mathematics. Okay, so then the child is said that you focus more on mathematics and then we'll see on in the next examination how well you do. So after 6 months, when the child sits for his uh, uh, sits for his 6 monthly examination, then he sees that he has progressed in mathematics. So similar is the IPCAF tool. You have an initial assessment first for the IPC practices for the current IPC situation that is there in your facility. Then there you identify the strength and the gaps that is there, and you can thus guide an action plan for future. And again after 6 months you can come back to see how much you have progressed. Again you so this goes on and you have 9 follow-up sections on IPCAF tool which you can do after the initial assessment. I'll come to that later on. So WHO proposes 5 steps for implementations of IPC facility program. The first is the preparing for action. Second is your baseline assessment. Third is your developing and executing an action plan. Fourth is your assessing impact. And fifth is your sustaining the program over the long term. This IPCAF tool, it supports section or steps 2 and 4 of this process. The baseline assessment is basically to understand the current IPC practices that are there in your facility. And fourth one, assessing impact, is basically for evaluating the effectiveness of activities or the action plans that you have developed and how well you can sustain it over long term. Who should complete and use the IPCAF tool? Basically, healthcare professional who has the knowledge of IPC practices, such as the HICC committee or the IPC committee, they can use the IPCAF tool. But if you do not have any professionals, IPC professional in charge in your healthcare facility, then that tool can easily be completed by the senior facility manager as well. So, the IPC committee basically consists of the IPC lead, IPC nurses, head of quality, and so on. And these are the roles and responsibilities defined for the IPC committee. How is IPCAF structured? IPCAF is basically a set of questionnaire with a total score of around 800 marks, and it is generally self-administered. That is, you can do it on your own. It is a self-assessment tool, and every 6 months you can do it in your healthcare facility. It also has a template for key observations, data interpretations, discussions, and action planning. The IPCAF tool is generally divided into 8 core components with 81 indicators or questions, and each question has a defined answers, and each answers has a defined score. So each section, these 8 sections, and each sections have 100 scores attributed to it. How is IPCAF structured? IPCAF is to be done, as I already said, every 6 months after the initial assessment. So when I'm talking about the follow-up sections as well as the initial sections, so when you look at the tool, I'll be giving a live demo after the session. So when you look at the tool, you'll see that you have a section for initial assessment, and then you have a 9 follow-up sections. So in this way, after you do the initial assessment, you can use the same IPCAF tool for 4.5 years in order to do the follow-up sessions for your progress and to see the improvement. So this 9 follow-up sections, it has the exact same 81 questions that is there in the initial assessment, and it has the same scoring system of 800 marks. Only the key observations, the recommendations, and the action plan will change based on the progress that you made over time. How does IPCAF work? So IPCAF basically you have a PDF version of the IPCAF as well as the Excel format of the IPCAF. So you have 81 questions or indicators. When you look at the PDF version of the IPCAF, you'll see a small footnote on each of the pages. And this footnote is basically there to help you with the new terms and terminologies in the stated questions. And we also recommend that if you do not understand anything while doing the IPCAF tool in your facility, you can always take the help of the guidelines on the core components of infection prevention and control that is there, and it is made by the World Health Organization. IPCAF scoring system. So each section, there are 8 sections, and each section generates a score between 0 to 100. Now, according to the final score, out of 800, the facility IPC program can be categorized into 4 levels, that is inadequate, basic, intermediate, and advanced. IPCAF scoring interpretation. Suppose a facility scores between 0 to 200, then that facility is categorized into an inadequate level. It means that the core components of IPC implementation is deficient in that facility and a significant improvement is required. And suppose if a facility scores between 400 to 600, then that facility is categorized into intermediate level, and we know that most of the IPC core components in that facility is appropriately implemented, and then there should be a focus on to improve the scope and quality of implementations and to sustain the change that is there during a long-term period. Can IPCAF be done by an external assessor? Yes, In joint evaluation, IPCAF can easily be done by an external assessor, but the external assessor has to be an IPC professional who is who has a complete understanding of the recommendations that is contained in the WHO guidelines and core components of IPC program. And IPCAF is basically designed for global use. It can be used for facilities of any size, of any medical focus, or in any developmental stages. Here we have a graph showing the comparison between the internal assessment versus the external assessment at a public health facilities in India. So we can see that there is a lot of difference in the score during the internal and the external assessment. During the internal assessment, all the public health facilities, they scored very high marks, such as 400, 500, 600, and so on. But during the external assessment, the same public health facility, they scored really less marks. The score went down up to 188, 170, and so on. But why is such a huge difference between the internal and the external assessment? So when we are using IPCAF for the first time, there are 81 questions and you have a lot of new terminologies in there. So it's a kind of an inexperience when you're using IPCAF tool for the first time. So the questions and the indicators may not be very clear to us. Then again, when you're doing internal assessment, the evaluation is generally not performed stringently. And of course, because it's our own institute, so we tend to have some kind of biasness. So it's always better, even after internal assessment, it's always better if you have an assessment by the external assessor also, along with the internal assessor. So there are 8 core components of IPCAF, as already said earlier. These are IPC programs, IPC guidelines, HI surveillance, multimodal strategies, workload, staffing, and bed occupancy, and so on. IPCAF core component 1, uh, it basically recommends that during the IPCAF assessment or for the IPC practices, we should have trained team in place in our healthcare facilities. For core component 2, the panel generally recommends that there should be guidelines for everything. There should be guidelines, there should be proper protocol, there should be SOP, so that the IPC practices and the HI surveillance practices, they can be implemented for the reduction of healthcare associated infection as well as AMR. Here are some of the questions that are there in core component 1 and core component 2. We'll get to these when we do the live demo. So the core component 3, in core component 3, the panel generally recommends that there should be education and awareness among all healthcare workers for IPC practices as well as for using IPCAF tool. The core component 4 basically deals with HI surveillance. So the panel recommends that facility-based HI surveillance should be performed to guide IPC interventions and detect outbreaks. Because in order to have a proper and quality healthcare facilities, we need to have 2 to 3 things, that is strict surveillance and solid IPC practices and AMR surveillance. These are some of the questions from core components 3 and 4. The core component 5, generally the panel recommends that the IPC activities should be done using the multimodal strategies. So what do you mean by multimodal strategies? According to WHO, the multimodal improvement strategies generally addresses 5 areas. The first area is the build it system. So suppose, for example, when you see that you do not have an alcohol-based hand rub at a particular point of care or in an ICU. So first is your build it, that is system change. So in order to have a system change, you should have an alcohol-based hand rub at every point of care or in the ICU. Now the second is teach it. So teach it comes under training and education. You have to make all the healthcare workers aware on how to use the hand rub, when to use the hand rub, when the healthcare worker is going from one patient to another patient, then the handbook is to be used, and so on. The third is check it. Check it means evaluation and feedback. You have to have a timely, routinely feedback in order to see how you're doing and how you're progressing. The fourth is sell it. Sell it, we means reminders in the workplace. Even after setting an alcohol-based hand rubs at point of care, you need to have some sort of reminders in place, such as posters or WhatsApp reminders, monthly or weekly, or email reminders, and so on. And the fifth is leave it. Leave it, basically by leave it means whatever changes we have done, we need to sustain it over time in order to see the real improvement. Now, this core component 6, the panel recommends that there should be regular monitoring and audit and timely feedback of healthcare workers, healthcare practices according to the IPC standards. Core component 7 basically deals with the workload, staffing, and bed occupancy. And here, in order to reduce the risk of HAI, the panel recommends that there should be certain things in place, such as the bed occupancy should not exceed the standard capacity of the facility, and the healthcare worker staffing level should always be adequately assigned according to the patient workload. The core component 8 basically deals with the built environment, that is the infrastructure of your healthcare facility, the material and the equipment for IPC. And the panel generally recommends that all healthcare workers and the patients should have access to a clean, hygienic environment, including clean, hygienic, potable water. Here are some of the questions from core components 6, 7, and 8. So this is the PDF version of the IPCAF tool, which was designed by WHO. And as you can see, it has a footnote for all the terminologies that is used in the PDF version, as well as the Excel version. Why Though we have the PDF version of the tool, but why a Microsoft Excel was developed? The Microsoft Excel tool was developed because in the PDF version, we could only do the initial assessment of the IPC practices in the facility. We couldn't do the follow-up sections. And in the Excel tool, you will see that you have 9 follow-up sections as well, which you can use for doing IPCAF every 6 months, and then you can progress your document, then you can document your progress over time using that tool, because at the end of the tool, you have graphs and tables, which is automatically generated after you give scores to each of the answers. So this is the Excel version of the tool. Here you can see you have core component 1, core component 2. Here you have the general information. You have action plan tab, you have data table and graph tab as well. In the upper left corner, you can see there is 1A designated under a red box. So this 1A is basically for initial assessment. Again, here also you can see under the red box, it is 1A, which designates that it is for initial assessment. And when you come to the right-hand corner or side, you'll see there is F1 designated under a red box, which designate that it is a follow-up section, and you can use this section after 6 months of doing your initial assessment. This is how the data table look like. We have filled the scores for the initial assessment as well as for follow-up 1. And this is how your data table looks like after auto-generating the results. This is how the graph looks like. I'll show you the graphs where we have completed all the 9 follow-up sections of IPCAF also. How can I make a work plan using IPCAF results? So when you want to make a work plan, you can have a table with strength and gaps and you can have a table with strength and gaps for all the core components of the IPCAF and see how you're progressing. So this is a study on IPCAF from our HI network. Here what we did, we sent the IPCAF tool to 32 hospitals, the soft version of the IPCAF tool, and asked them to complete it. After receiving the completed IPCAF tool from there, from all the participating sites, we did analyze the results and saw that the overall median score of IPCAF across the network was 6620. And based on the final IPCAF score, 4 hospitals had basic IPC practices, 9 hospitals had intermediate, and 19 hospitals had advanced IPC practices. This is the result from the same study where scoring between where uh, there is a score for the government as well as the private sector, and through this graph we can already observe that the private sector have scored well during IPCAF assessment. This is because obviously the facilities in the private sector is much different from the government sector, and the IPC practices are much stringent in the private sector than the government sector. Is the IPCAF tool suitable for interfacility comparison? We generally do not recommend using IPCAF tool for interfacility comparison because every facility is different, particularly in terms of sizes, medical focus, and especially in terms of socioeconomic setting. You generally cannot compare between a state government hospital and a private hospital, or a state government hospital with a central government hospital. So it's really difficult to use the IPCAF tool for interfacility comparison. But yeah, this tool can be used basically for benchmarking. Common mistakes when using the IPCAF tool. When we're using the IPCAF tool, basically the common mistakes that we find that sites are doing, they do the IPCAF tool in absence of IPC professional or expert. But we always recommend that while you do the IPCAF tool, there has to be an IPC professional present. Whether it is an internal assessor or an external assessor, it doesn't matter, but the person should have an IPC knowledge. Then again, the indicators of the questions are not clear. So while filling out the IPCAF tool, many people, what they do, they fill out the answers without understanding the questions. So that is also not the correct way of doing the IPCAF tool. You can always go back to the guidelines that is there by the WHO and see, because there you can find elaborate definitions of every terminology that has been used in the IPCAF tool. So before going for an IPCAF tool, kindly go to the guidelines and read that document. It is a 91-page document. You do not have to read everything, but yeah, you can just find out what you exactly need to understand and go through those. Then again, not assigning score to every indicators. Most of the time we see that when you're doing the IPCAF tool, uh, most of the people, they do not assign score to every indicators, especially when they're using the Excel tool, because when you're using it for the first time, there may be some confusion, and the person may just skip one or just skip assigning the score to every questions. Then again, the most important mistake that we see is not doing follow-up assessment after the initial baseline assessment. If you just do a initial baseline assessment and not do a follow-up assessment, then you won't be able to understand the progress that you're making along the line. So it's very important to do the follow-up assessment as well. Again, there is a risk of biasness because when we are doing it for our own facility, we try to overestimate the scores, not putting the scores that reflect the current practices. And again, one of the common mistake that is there is not having ongoing discussions and using the results in the HICC meeting. You do the IPCAF tool, you complete it, you have a score with you, but again, when you're not discussing it with your HICC committee or with your IPC committee, it is basically of no use. So it's very important to use this tool very diligently and honestly. So what is required for implementation of IPC core components? The most important thing that is required is the effective leadership along with the IPC committee or HICC committee that have an engagement of IPC professionals all the time. Then there are multimodal or multidisciplinary strategies that you can follow. There has to be a feedback or monitoring approaches all the time. It should be patient-centered, integrated within a clinical procedures, and it should be innovative and locally adapted. Main challenges to implement IPC in middle income countries. We basically know that HAIs and IPCs are generally not on the top of the priority list of the national health agenda. There is always a gap between policy and actual implementations. And the most the most challenging part is the lack of reliable data on healthcare associated infections. Then there is limited access to qualified and trained IPC professionals and so on. But we need to have some sort of system in place. We need to start, even it is small, we need to start somewhere, because assessment basically and its data is extremely important to improve IPC practices in any facility. So here my lecture ends, and I acknowledge Dr. Purva Mathur and of AIIMS New Delhi. I also acknowledge Dr. Valan and Dr. Daniel of CTC India, my AIIMS team, and World Health Organization. Now, I'll directly go to the, I'll try to show you the live demo using the Excel format of the IPCAP tool. Is there any question as of now? You can type in the question in the chat box, and we can discuss it at the end of the session. I'll try to share the Excel format of the tool. Is it visible?
Yes, it's visible, Rasna. It's visible.
Thank you. Thank you, ma'am. So this is the Excel format of the IPCAF tool. In the first tab, you have all the general information for this tool. Here you can see the why we are using the tool and how to use the tool. It has the general information all the way. Now we come to core components 1. Okay. The core component 1 is, yeah. So here on the left hand side in the upper corner, you see there is 1A. So this is basically for initial assessment. And you have general informations that you have to put in over here, such as when you're using IPCAF tool for the first time. Suppose you type in the hospital name, such as XYZ. You have to put in the address of the hospital, what kind of a healthcare level facility it is. You have a drop down menu as well, and for some tab you need to put in your answers manually, but for most of the tab you have a drop down menu. Suppose we choose primary care from here. Hospital type, you can choose district hospital. You have to put the name of hospital medical superintendent over here. So this section basically deals with the general information. When you come down, you have the core component 1. Similarly, you have core, if I go to the tab core component 2, you have core questions for core component 2 over here. Let me fill core component 1 for you. It has 6 questions, sorry. It has 10 questions. So let me fill core component 1 for you. The first question is, do you have an IPC program? So there are 3 options for this question. The first option is no. The second option is yes, but without a clearly defined objectives. And the third option is yes, but with clearly defined objectives and annual activity plan. So suppose if you say, yes, we have an IPC program, but without a clearly defined objectives, then you go to this score panel and you select 5 from here. Now we come to question number 2. Is the IPC program supported by an IPC team comprising of IPC professional? If you say yes, again you come down over here and assign a score of 10. For third questions, does the IPC team have at least one full-time IPC professional or equivalent nurse or doctor working 100% for IPC available? Again, you have 4 options for this question. If you say yes, 1 per 250 bed, more than 250 bed, then you can assign a score of 5. Because each answers or each indicator, they have a defined score against them. So as you answer, you can assign score accordingly. Question number 4, does the IPC team or focal person have dedicated time for IPC activities? If you say yes, again, you can assign a score of 10. Question number 5, does the IPC team include both doctors and nurses activities? Again, if you say yes, you can assign a score of 10. So most of the tab, as you can see, have drop down options. Question number 6, do you have an IPC committee actively supporting the IPC team? If you again say yes, it's a 10. Now we come to question number 7. Are any of the following professional groups represented, included in the IPC committee? Senior facility leadership or CEO or medical director? So if you say no, it's a 0. If you say yes, senior clinical staffs are there, so you can assign a score of 2.5. Because if you say yes, 2.5 score is assigned against yes. If you say facility management is also there, so you can again assign a score of 2.5 over here. We come to our next question. Do you have clearly defined IPC objectives that is in specific critical area? If you say yes, but only the objectives are defined, assign a score of 2.5 over here. The next question is, does the senior facility leadership show clear commitment and support for the IPC program? There are 2 options over here, and you have to answer to both of these questions. By an allocated budget specifically for the IPC program, if you say no, assign a score of 0. And when we come to our next answer, if we say yes, by demonstrable support for IPC objectives, the facility is there. If we say yes, then we can assign a score of 5 again. And last question is, does your facility have microbiological laboratory support for routine day-to-day use? Suppose if you say no, we do not have a microbiological laboratory, then you can assign a score of 0 over here. So here at the end of this section, you can see that we have a total score of core component 1, that is 62.5. And when we go to the data table and graph over here, we can see in the initial assessment panel, the score is visible. 62.5 is there. Okay. Okay. We also have one more score because core component 5 is also filled over here. So in this way, you can assign a score to every answer. Now, where you have said yes, that's fine. But where you have said no, suppose you do not have a particular facility. For example, here we have said that we do not have an allocated budget specifically for the IPC program. So you can have your recommendations. Here first you have to write your key observations, what you have exactly observed. I suppose I write IPC budget, IPC budget not allocated. This is my key observation. Here you have the panel. the column for key observation after assigning the score. So you can put in your key observation over here. And then just after key observation, you have the current recommendations by assessment team. You can put in your assessment over here. Just hold. Yes. Yeah. You can put in your current recommendations over here. IPC budget need to be discussed with higher authority and allocated. So here you can put your current recommendations. Action plan. For action plan, you can suggest a high level meeting with the hospital with hospital management for discussion of IPC budget. So in this way, you can fill in your IPCAF tool. So this can be done for core component 1, for core component 2, and so on. And at the end of the follow-up sections and the initial assessment, you can have a table and graph that is automatically generated after this tool is completed. You can see the graph over here because here we have done the follow-up session 1 and the initial assessment. That is why it is reflecting for both the things. Yeah. So now I would also like to show you one more IPCAF tool which is completed. This is my IPCAF tool which we have completed for all the follow-up sessions. Here you have the initial assessment. If you can see on the left hand side, here you have the initial assessment. Just after the initial assessment, you have the follow-up review 1. Again, you have the follow-up review 2. So after the initial assessment, you have to come back again after every 6 months. You have the same questions, the same assigned score in every follow-up sections, and you have the same core components. Only the recommendations, the key observations, and the action plan will change based on what progress you have made during the last 6 months. So in this way, you have all the follow-up sections up till follow-up sections 9. And let me show you the table and graph because this is a completed tool for all the 9 follow-up sections. Yeah. See, we have the total score for all the follow-up sections over here. And we have the graph which looks like this after we complete the IPCAF tool for all the initial assessment as well as the follow-up sections. So the graph exactly looks like this. You have separate graph for core component 1, for core component 2, and for other core component as well. And you have an aggregate graph as well for all the core components. I want to show you certain things as well. Okay. So this is basically the guidelines on core components of infection prevention and control, which is a 91-page document. When you're doing an IPCAF tool, and if you do not understand any terms or terminology in there, you can always come to these guidelines and you can always take the help of these guidelines because it has everything elaborated in here on all the core components of IPC practices, and it was developed by WHO. Now, I want to show you one more thing. Suppose if you do not understand the IPCAF tool during your initial assessment, because it is quite a big tool, we can say, and it has 81 questions, and all the 81 questions are not easy to understand, because when we were doing the IPCAF tool for the first time, we also got stuck in some of the questions. So here you have a shorter version of the IPCAF tool, which was again developed by WHO. It generally have only 27 indicators of questions, and it consists of only 26 marks. So before going for the original version of the IPCAF tool, you can always take the help of this shorter version of the IPCAF tool and see exactly where your healthcare facility stands, because it has only 27 questions. So you can easily go through these. You can assign a score, and it consists of only 26 marks as opposed to 800 marks that is there in the original IPCAF tool. So these are all about IPCAF, and I'll stop sharing my screen. Yeah. If you have any questions. So, yeah, we have one more question. So, here, a person has asked, do we have this tool customized to various level of facilities? Means for subcenters like PSC, CHC, and district hospital, or same for all. This IPCAF tool is basically for acute healthcare facilities. It can be used for district hospitals as well, but it has a lot of questions where the score that you may get may be zero, because basically in maximum district hospitals we see that there is no facility of microbiological laboratory or something like that, and you can use it. But we recommend that you use for district hospital or for PSC, etc. First, you use the shorter version of the IPCAF tool, which I showed you just now. And if you're comfortable, then you can use the original version of the IPCAF tool. I'll just look in the chat box and see if there are more questions. Yes, we have everything available with us. So I'll share it with NHSRC, all the documents, and the Excel version of the tool, the PDF version, including the guidelines, and the shorter version of the tool as well. And if need be, I can share the PPT as well. Okay. One person has asked, who is the IPC professional? So IPC professional is basically the one who generally assess the infection prevention and control practices in your hospital. The IPC professional is the one who basically sees whether your hospital is having, for example, a basic hand hygiene station or not, whether you're following all the IPC practices, whether you have all the guidelines for IPC practices or not. So IPC professionals are those who basically do the assessment for IPC practices in your hospital.
So I can just add IPC professional can be a microbiologist, and it can be an infection control nurse. It can also be a clinician who is working in ICU and who is working in infection control. So there is no separate cadre for IPC professional. Anybody with the requisite knowledge and the commitment and time can be an IPC professional.
Yeah. There was one more question. Somebody asked if the tool is basically meant to compare the progress of a particular facility only. Yes, as we already discussed, it is generally not used for inter-facility comparison, but you can just document the progress of your own facility over time by using this IPCAF tool every 6 months. So it can be used for your own facility in order to compare your own progress over time. So I think there are no more questions, as I can see in the chat box.
So thank you so much, Rasna, Dr. Rasna. That was very insightful and detailed. I am seeing some of the comments
Thank
and
you, ma'am.
chats. You need the PowerPoints, you need the guidelines. Everything will be given to you through NHSRC. We will be handing over the PowerPoints the guidance document as well as the Excel sheet, the short and long one, to you. And because we are actually today we have only district hospitals and CHCs and PHCs, and this tool is made for all kinds of facilities. So if you see the WHO's multi-model strategy, there are 8 components. And for each of the 8 components, they have different indicators for tertiary hospitals, secondary and primary hospitals. So the indicators are the same, but the expectations are different. So WHO has made this tool understanding the fact that a tertiary hospital is obviously going to have more facilities than a district level and a primary hospital level. So say the component of HAI surveillance, okay, so if you see the component on HAI surveillance, the WHO has different indicators for tertiary hospital. That for tertiary hospital, they are doing surveillance for everything, BSI, UTI, VAP. There is a system, there is a budget. For district hospital, they just need, a team which is working on particular components on HAI surveillance. And for district hospital and for primary hospital, they do not recommend that a systematic surveillance program should be there. So, there is a recognition that the level of availability of facilities at different hospitals will be different, and that is why you can go to the main document and the WHO's multi-model strategy, which can be available from the net, or we can provide it to NHSRC, and you can see how well structured it is for different tiers of healthcare facilities, and that is how you can bridge the gap. And what are the expectations even in LMICs, lower and middle income countries, district hospitals? What are the basics? So for district hospitals, they have clearly suggested what are the basics that are needed as per the WHO criteria. So uh, thank you so much for this session. If anybody has any query, if anybody is facing any challenge while filling this tool, you can always reach out to us. We had provided you with our email ID, which is haisindiaaims@gmail.com. So you can write to us or you can write to the NHSRC team. They will get back to us if you are finding it difficult to fill any component. So with that, I hand over to the NHSRC team to give the closing remarks, please.
Thank you, ma'am. Thank you so much. And thanks, Rachna, for a very lucid presentation. And I think it is very much appreciated because people are giving the feedback in between that it's quite informative and quite simple. And
Thank you so
thank you.
much, ma'am.
Yeah, thank you, ma'am, for your all support, and I hope that we will be able to cover most of the participants this time because few of them has already attended the training last time, but few are still left, and I can see that almost 300, 400 people have joined. Maybe many of them are repeating this particular training. So thank you so much. And as ma'am has communicated that from NHRC side, we are sharing a kind of Excel sheet which have this IFCAP tool. So you can submit your response in that sheet, and based on that particular sheet, we will look into your overall preparedness for this new initiative, and a further guideline will be developed according to it. And we are definitely means and all the material etc is available in AIIMS website also and in NHRC website also. But apart from that, whosoever has attended today's training, we are going to send the, link of the Excel sheet to your respective email IDs, as well as we are going to share it through the WhatsApp group also. And as sir has said that within 10 days, that if you will be able to give us the filled sheets etc, then we would be able to evaluate. And your certificate is also sent along with the link that we are going to give you for IFCAP evaluation. So From our side, you can contact me or you can contact Arpita, and Ranjit is there, so you can contact any one of us related to any query, and you can even contact Rasna and AIIMS team also if you have some query. So both channels are open. You can contact us or you can contact AIIMS team, or maybe like you can contact us and then we will get you connected with the AIIMS team in case you are not able to connect directly. So with this, thank you so much from our side. And if you have any query, you can write in the chat box. And even if few of your colleagues are not able to attend this particular workshop, then we are also going to share a YouTube link also where you can see the session if you are not able to attend that particular session. So once again, thank you, ma'am. Thank you so much for your all support. And we are hoping that we will be reaching at, for first phase, maybe the first step, maybe we will be able to take in next 10 days, ma'am. Thank you. Thank you so much once
So
again,
much.
ma'am.
I'll just add one more thing that, as Dr. Rasna said, don't worry about your scores, please. So out of 800, even if you get 100, it's a great opportunity to reach 200 next time. So this tool is not for interfacility comparison or for publicizing it anywhere. All information is coded. There is no individual facility that is brought to the notice. It is only for yourself. So even if you get low scores, you can take it as an opportunity for improvement. And generally, we have seen that it's generally a red flag if the first baseline assessment is very high scoring, even for tertiary hospital. So we had some facilities who had got very high marks, in the first assessment, and then we reached out to them because if you are 800 on 800, then there is no scope for improvement, right? You have everything. So high scores are generally red flags for us. We always feel that there are always gaps and there are always opportunities for improvement. So take it as a tool for self improvement. So thank you so much. You can reach out to NHSRC team or the AIIMS team, and please submit your baseline assessment by 20th or 21st, as Shivastava sir had mentioned. Uh, that's all from my side. Thank you so much.
Thank you all.
Thank you. Thank you so much, everyone.
Yeah, thank you.